Welcome, everybody, to another exciting Wu University event. Tonight, I am joined by three experts in the keratoconus field, and this is a very highly requested topic. My name is Dr. Stephanie Wu. I am the founder of Wu University, and I will be your host for this evening. So it's my pleasure to introduce the three doctors for this evening. First, we have Dr. Peter Hirsch. Dr. Hirsch graduated from Princeton University and received his medical degree from Johns Hopkins Medical School. He completed his ophthalmology residency training at Harvard Medical School and also received his fellowship in corneal surgery, the same area. Here are his financial disclosures. Dr. John Gellies graduated from the University of Oregon and received his optometry degree from the Pennsylvania College of Optometry. Dr. Gellies is the first and only Boston site PROS clinical fellow and PROS provider in the state of New Jersey. And here are Dr. Gellies' disclosures. And then last but not least, Dr. Stephen Greenstein. Dr. Greenstein received his medical degree from the Albert Einstein College of Medicine. He completed his ophthalmology residency at Rutgers, New Jersey Medical School, and he then completed a cornea refractive fellowship at Mass Eye at Harvard Medical School. All three doctors work together at the Cornea and Laser Eye Institute. They are all very well respected in the industry of anterior segment disease and keratoconus. So you guys are very lucky to be listening to three experts tonight. I'm very excited for this course. Dr. Hirsch, please take it away.
Thank you, Dr. Wu, and my thanks to both you and to CorneaGen for putting together tonight's webinar on a very exciting subject. It's a subject that really encompasses all of refractive surgery going back almost 70 years. And that's what we call corneal inlays for keratoconus, past, present, and future. Modern keratoconus management, unlike in the old days, where all we had was the ability to either fit a contact lens or go directly to corneal transplant, has a lot more alternatives nowadays. We call it KC 1, 2, 3. Number one, we want to stabilize the cornea. Number two, we want to improve corneal topography. And three, we want to optimize vision. Well, let's look at stabilizing the cornea. We've discussed many webinars in the past about corneal collagen cross-linking. Corneal cross-linking was probably the most important innovation to occur in keratoconus really over the past century since the invention of contact lenses. Corneal cross-linking stabilizes the cornea and prevents progression of the disease. However, it is not made to improve the corneal topography, and it is not made to improve vision. It solely and exclusively aims to decrease keratoconic progression. And since progression is the most important predictor of the need for corneal transplant, it has been an extraordinarily important advancement in the treatment of keratoconus, but more on that later. Now, we are also able nowadays to improve corneal topography, and that's why we're here tonight. This can be done via intracorneal rings, Topography Guided PRK, and conductive keratoplasty. I'm going to concentrate on inlays, and then Dr. Greenstein is going to discuss some of the other innovations in corneal management of keratoconus. And then finally, how do we give the patient better vision? We want to improve vision. Glasses, contact lenses, they're implantable lenses available as well nowadays. But we're going to concentrate with Dr. Gellies' expertise on the use of contact lenses after implant procedures. Well, let's go way back. The grandfather of refractive surgery was Jose Barraquer from Colombia. In 1949, he wrote the book Refractive Keratoplasty. It was really the introduction in the entire eye care field to changing the refraction of the cornea in order to improve vision. The way he did this was rather rudimentary. He would remove a lamellar portion of the cornea from the patient's eye using a handheld, what almost looks like a salami slicer, as you see in this illustration. He then took a contact lens cryolathe and actually lathed the patient's corneal tissue and then replaced it. These were called the keratomileusis and keratophakia procedures. Well, let's jump ahead then 30 years to epikeratoplasty. This was first described by Ted Werbelin and Herb Kaufman at LSU. And what they did here was commercially take preserved corneal tissue, they lyophilized it, they would shape it much as one would shape a contact lens, and then we would suture it onto the surface of the cornea, as you see here. And they used to call this the implantable living contact lens. Suffice it to say, all of these procedures didn't work well. They were complicated with problems such as epithelial ingrowth, haze, scarring, and surface irregularity. So they really didn't go much farther than a couple of years. At the same time, people were developing artificial inlays. This was first made of plexiglass, as introduced again by Dr. Barraquer. People tried polysulfone and hydrogels. However, all of them led to poor wound healing and really ocular surfaces that were not optically appropriate. Well, one thing that was shown to work were intracorneal ring segments. There are 3 varieties of these commercially. We use Intacs here in the United States. There are also Ferrara rings and Kera rings, all come in somewhat slightly different configurations. But when I am introducing this concept to the patient, I say, picture a contact lens, punch a hole in it, cut it in half. These rings are implanted into your cornea in order to provide structural support and to improve the corneal topography to get you better vision. Now, Intacs for keratoconus took kind of a backdoor route to their utilization. Intacs were originally FDA approved in 1998 for myopia. You would implant 2 of these and they would flatten the cornea to correct myopia. Suffice it to say, they weren't as good for refractive corrections as LASIK and PRK, so they really fell into disuse. However, Dr. Philippe Collin in France started using them for keratoconus. And the FDA approved Intacs for keratoconus under a humanitarian device exemption in 2004. So we've been using Intacs for about the past 17 years for the treatment of keratoconus. How do Intacs work? They add additional support and strength to the cornea. And as you see in this video, when they are placed, they form an outward pressure, think of a tent pole, which causes a secondary flattening of the cone. So what we're doing here is we're applying the Intacs to strengthen the cornea, but also to flatten the cone. So it really has 2 uses. Here is an actual patient that we treated. This is a Scheimpflug image showing the peripheral cornea. Here's the anterior cornea, posterior cornea, untreated cornea, and where the Intacs is. This is the original corneal shape. So it is low in the periphery and it rises over the keratoconic cone. The Intacs are then placed, and you can see them here in cross section. So they act as a spacer, increasing the thickness of the cornea in that area. And if you follow this red line, you'll see that the cornea actually elevates somewhat directly over the Intacs, but it flattens over the cone, giving the cornea a more natural, spherical, dome-like shaped contour that an optically viable and optically functional cornea enjoys. And that shows us the difference before and after. And this is an actual patient. So here you see on the left side is a patient with a cone, of the red area, of course, is the cone with a maximum keratometry of 57.1. We then placed a single segment Intacs, and you can see here that the corneal topography has become much better. The cone has shrunk, the elevation has decreased, and if you look at the difference map here, you can see a flattening over the cone area with a much improved corneal topography. So this is really the goal of the Intacs procedure. Another example, this is a height map. So looking at the purple areas up top, this is an elevation over the normal cornea. This is where the keratoconic cone is, and this is where the patient is seeing before surgery and after surgery. And if we zoom into the optical zone, you can see that the central optical zone is much more homogeneous and green. With this, the patient should enjoy better vision. So again, with Intacs, we're applying them to improve the corneal topography, to improve the patient's vision. Now, when planning patient surgery, we will either plan for 2 segments or 1 segment. 2 segments are really reserved for central cones with low degrees of astigmatism. So here you see again a before and an after. The cone has shrunk. You have a general flattening of the cornea. The preponderance of our treatments nowadays, however, is using 1 segment, because a vast majority of keratoconic patients don't have centered cones. Rather, most have cones that are displaced inferiorly. And we find that the 1 segment outcome, both from the point of view of vision, corneal topography, and any side effects, is much better. So here's that example, or another example. Before, after, you see the cone is shrunk, and here you see just flattening in the area of the Intacs, with steepening indeed 180 degrees away, which is something that we want. Because one thing that you don't realize in a keratoconic cornea, picture the cornea as sagging. So the top of the cornea is actually flat, the cone is steep. So the goal of the Intacs would be to flatten the steep area and orthogonally steepen the flat area, which leads to a more homogeneous corneal topography. Just an example of how we treat the patient. In the past, we did a manual dissection, but now these are all done with femtosecond laser. This creates a channel. We open the channels and then place the Intacs surgically. Usually, no suture is necessary because when we use just 1 Intac, we displace the edge of the Intac from the incision. So there is little risk of the Intac extruding or gaping the wound. So there's no need for a suture in these cases, which makes it a much more patient-friendly procedure and has also decreased any side effects of the Intacs moving. After surgery, patients get antibiotic drops for a week and anti-inflammatory drops tapering over 3 weeks. And here you see again a well-positioned Intac, and here you see a cross-section of the Intacs, which are generally about 80% deep into the cornea. Now, let's look at Intacs and cross-linking because these often will be combined. Again, the goals are entirely different. Intacs to improve corneal symmetry, to flatten the cone, cross-linking to strengthen the cornea and decrease progression. Remember, when people ask you about cross-linking, the goal is really decrease progression. It is not to improve the patient's vision, though some patients do, in fact, have a slightly improved topography and a slightly improved vision. So we had a randomized prospective trial of 198 eyes, where we looked at combined Intacs and cross-linking at one session, and Intacs followed by cross-linking 3 months later. Our goal was twofold: to see how was the effectiveness of the Intacs and cross-linking in general on the patient's quality of vision. And second, did it matter if you did them together, or did it matter if you separated them by 3 months? First, let's look at maximum flattening. If we look at the topography here, what we're looking at is the area of the topography where the cornea has flattened. And we see, indeed, if you look just at this number, we can get upwards of a 10 diopter flattening over the cone with Intacs. We get our most effect with a thicker single segment. The different segments show different kinds of effects, so we can grade this to the particular patient and give the right size and placement of the Intac depending on the degree and placement of their cone. Another important topography metric is the IS value. That is, what is the difference between the power of the cornea superiorly and inferiorly? Here you see an almost bifocal corneal topography. Here we place the Intac, and you can see below that the topography is much better, but the superior-inferior difference in particular is much improved. And the corneal topography difference map shows a flattening of the cone below and a steepening above. Again, let's just look at the circled number here, and we can see that we can improve the IS ratio by upwards of 5 diopters, which is a very important improvement in the patient's corneal configuration. Higher order aberrations are the optical problem that one does have with keratoconus. Because the corneal dome-like clear structure, because of the biomechanical instability of keratoconus misshapens, forming an irregularity, it scatters light. And we call that the signal-to-noise ratio. So in a perfect optical system, if 100 rays of light enter the cornea, 100 rays of light will be focused on the fovea. But in a circumstance with poor optics, such as keratoconus, there is a scatter of that light, an increase in noise light, or what we call visual static to the patient, with secondary consequences of poor vision, decreased night vision function, poor contrast sensitivity, and other problems. When we looked at corneal higher order aberrations after cross-linking and Intacs, and we found that there was a substantial improvement in total aberrations, in coma aberrations, which is the difference between the top and bottom of the topography, the IS ratio, so to speak. So they certainly have an improvement in their aberrations after the Intacs procedure, which should give better vision. And indeed, if we look at visual acuity after cross-linking and Intacs, it does improve. Again, I'll just point to this one group with single segment 450 Intacs, and they improved by 0.3 logmar lines for 3 Snellen lines of visual acuity improvement. So one is getting a substantial topographic and vision improvement after insertion of the Intacs. Now, to answer the question, does timing matter? timing does not appear to affect the results. If we look at the concurrent and sequentials, the degree of topography change is similar between the two. So very frequently we're doing both together, but sometimes because of particular patient problems or needs, we will do one first or the other one first. So I'm going to turn the podium to Dr. Greenstein, who can share a little bit more on who should have Intacs placed and some of the other options that have evolved over the years.
All right. Well, thank you, Dr. Hirsch. That was a great start to how Intacs work. So the next portion that I want to spend a little bit of time on now is who should have Intacs placed. And we've learned a lot about this over the years, placing Intacs segments. And primarily, the goal of placing the Intacs segment is to improve a patient's vision in glasses. So as we'll see moving forward, one of the optimal patients to place Intacs in are patients who need better balance in the vision between their two eyes in glasses. The evolving area where Intacs is proving to be very, very useful is combined with other topography altering procedures, because we can use an Intacs segment to flatten the cornea. And as Dr. Hirsch showed, we can flatten the cornea by sometimes up to close to 10 diopters, and then use some other procedures to further flatten the cornea and further make the cornea a more symmetric shape, which can further improve a patient's vision. And finally, as we also saw in the outcomes, we can even improve patients' vision without glasses, although that's never the guarantee with any of these surgeries. One thing that you'll notice here is that less and less we're using Intacs to improve contact lens fit. As Dr. Gelles will go over later, Intacs really is proven to help patients in the times that they're not wearing their lenses and get more functional vision that way. And then they can continue to use their lenses during the day to get even better vision. So here's a case where Intacs proved to be very, very valuable. So this is a pretty typical case, 22-year-old male with keratoconus. He had worse keratoconus in the left eye than the right. And he came in with an uncorrected vision in the right eye of 21/25 and in the left eye of counting fingers. And if we look at his glasses prescription, what we see here is there's a certain degree of anisometropia, but also his vision is fairly uncorrectable in the left eye. So he corrects very, very well in the right eye to 20/20. And in the left eye, we can only get him to 2100. So in this case, we offered this patient to have a single Intacs segment placed and simultaneous cross-linking, which has pretty much become our go-to now that in our study, we see that there was no difference between sequential versus simultaneous treatment. And if we look at the topography down below, once again, preoperatively, what we see is a pretty typical keratoconic patient with the inferior steepening of the cone down below and flattening up top. And if we place the Intacs segment right around the cone, what we see in the difference map is this large area of inferior flattening with the corresponding steepening up top, as Dr. Hirsch went over before. And if we look at the post-op map in the center, you can clearly see that the cone is much smaller and much flatter than preoperatively. Most important, if we look up top, 4 months later, this patient's vision, uncorrected vision, has gone from counting fingers to 2100, but their vision in glasses is now 20/25 plus 2. So if we look at their glasses prescription, what we see is there is no longer any anisometropia, and their vision is much more correctable and much more symmetric. So beforehand, the vision was 20/20 in the right eye and 2100, and now it's 20/20 and 20/25. Now, what happens when we place the Intacs segment, but we don't immediately get a result like we just saw in our previous patient? So there are additional treatments that we can use, usually sequentially with Intacs, to further improve the corneal shape and patient's vision. One of those treatments is topography guided PRK, and the other is conductive keratoplasty. So topography guided PRK uses the excimer laser, which places thousands of small spots to ablate the cornea. And we place those spots in a particular pattern, and that's how we reshape the cornea. So traditionally for LASIK and for refractive surgery, we're placing those spots in a pattern to improve a patient's myopia or hyperopia or astigmatism. But with topography guided PRK, we're using the placido disc image. We're using the maps of the patient's cornea to guide this spot placement and to reshape the cornea. Now, topography guided PRK is off-label in general, and for keratoconus is an off-label use. So here's an example of where topography guided PRK helped another one of our patients. So again, if we look at the picture in the top left, we can see a typical map that's generated from the placido disc image that we take by the laser to show how the cornea is going to be treated. And the purple areas are the areas where the laser is going to ablate more tissue and flatten the cornea. And in this case, most of that flattening is going to happen over a very central cone. So if we look at the picture at the bottom left, this patient has a very central steepening, a very central cone, which is why initially they had 2 Intacs segments placed. And their vision did improve. Their vision, uncorrected vision is 2200, but in glasses, this patient's vision can be improved to 2040. However, this patient in particular, their other eye, uncorrected, was 2025. So for a patient like this, they're really not very interested and don't see much of a benefit to wearing their glasses since their vision is so good in their left eye, and didn't really want to wear necessarily a contact lens in that eye as well. So what we can see in the picture in the top right is the area where the laser has ablated the cornea and flatten the cornea, again, right in that central area, right between the Intacs segments, to further flatten the cone. And if we look down below, just in the area of steepening, all of this blue area is where the cornea is now flattened. And if we look at the central picture, what we can see is a very green central cornea where the cornea is very symmetric. And as expected, postoperatively, this patient's uncorrected vision was 20/25. So what we can see is that for different patients, there are different treatments which we have to gear towards the patient's goals and towards their preoperative refractions. In the first case, our goal was to improve the patient's glasses vision, make their glasses vision more symmetric. And in this case, we're trying to make this patient's uncorrected vision more symmetric. But Intacs is the first step to get us to that point for both patients. Conductive keratoplasty works a little bit differently. For conductive keratoplasty, we're using a radio frequency probe, which releases thermal energy and causes collagen shrinkage. And in the area of each spot, we induce flattening, and then there's steepening right inside of the spots that you place. Now, conductive keratoplasty is approved for small degrees of hyperopia and for presbyopia. And again, using it in keratoconus is an off-label use of CK. So here's a case where, again, when we look at this patient's topography, it's very typical inferior steepening and an inferior asymmetric cone. And if you place an Intacs segment down below, as expected, we should get some flattening right inside of the segment. But what you also notice is that up top, and Dr. Hirsch was talking about this before, the portion of the keratoconic cornea that sometimes goes unnoticed is how flat they are superiorly. And with their steepening down below, even if you make that much flatter, if you don't steepen them up top, you still have a fairly asymmetric cornea. So in this case, if you place a few CK spots in the blue area, in the flat area, what you get is flattening down below, right around the cone, and steepening up top. And you can see in the post-op image a much more regular and symmetric central cornea, which can be much better corrected in glasses. Now, there are cases as well where Intacs may not work. And we looked back at the Intacs segments which we had placed in our practice, and we looked at over 590 segments which were placed. These were specifically with our femto laser. And what we found is that just over 6% of the Intacs that we placed had to be removed. Over half of those cases were removed for optical reasons. Either they subjectively were noticing more glare or halo, or the glasses prescription and the refraction wasn't improved with the segment. Now, this number is getting less and less as we've started to use some of these other modalities like the Topography Guided PRK and like CK to further improve patients' corneas. And then just under half of the patients had to have their Intacs segment removed for a medical complication, either inflammation, extrusion, or infection. But one of the nice things about Intacs is that when they are removed, the cornea generally returns to its original shape. So here is a patient who had an Intacs segment placed, and topographically, they have a very good result. What we can see in the difference map, as we've showed multiple times tonight, we have a pretty significant area of flattening down below with some steepening up top. And clearly in the picture after the Intacs segment was placed, the cornea is flatter and the cone is smaller. But unfortunately, this patient continued to complain of double vision after their Intacs segment was placed. So we removed the Intacs segment. And what you can see in the difference map now is that the entire area where the Intacs segment was placed has now steepened, and that is the red area that you see. And after removal, the cornea has steepened as well. So if we compare before the Intacs was placed and after the removal, what we can see is that the corneal shape has generally returned back to its original curvature. And so one thing that patients can be reassured about is that if, in the unlikely event, their Intacs segment has to be removed, in general, their corneal shape will return back to the way it was. One of the exciting areas that we want to touch on a little bit tonight is corneal tissue inlays. And this is sort of the next iteration of corneal inlays, and it combines a little bit of the history that Dr. Hirsch went over at the beginning with the development of Intacs and what we've learned about placing Intacs segments over the years. Now, there are some clear advantages to corneal tissue inlays. There's improved biocompatibility. It can be used in a wider range of cases, and we can treat more severe cases and thinner corneas. There are many different iterations of corneal tissue inlays. There's Bowman layer transplant. There's lenticules that are placed inside of usually stromal pockets. And then there are multiple versions of corneal segments and corneal inlays similar to Intacs segments, but made of corneal tissue. And that's what I'd like to focus on for the rest of tonight. Now, there are two forms of these inlays. One is called KERS, and that is an inlay which is created from fresh tissue, and KERANatural, which is created from preserved corneal tissue. And both of these inlays are cut very similar to Intacs segments. So similar to the way Dr. Hirsch described Intacs to a patient with a contact lens, punch out the center, and then end up cutting it in half. And these are then cut into 180-degree segments or a 360-degree ring, which can be inserted into the cornea. CTAC is a little bit different. CTAC also uses a preserved corneal tissue, which is shelf stable and slightly more rigid from the sterilization process. But it is a customized tissue addition for keratoconus. And the key is that the CTAC segment can be customized with the femtosecond laser so that we can customize its width, its thickness, and its length to each patient's individual cornea. And this is allowing us to achieve even better results with greater flattening and more improvement in visual acuity. So some of the limitations that we can have with current inlays, including Intacs, is that if the cornea is too thin, we may not be able to place the segment deep enough, and so those patients can't have an intact segment placed. Sometimes, because of the cone location, if we can't get the segment around the entire cone or close enough to the cone, then we can't get an adequate flattening to correct the patient's vision. And sometimes the cornea is just too steep. So even with our thickest segments, we can't place them in a meaningful way to get enough flattening in the cornea. But now we can customize these segments for thinner corneas. We can customize them to fit right around the cone. And we can customize them to induce more flattening for these steeper cases. And here's an example of the wide range of patients who can be treated with a CTAC segment. So on the top, we can see a much more severe central cone. This patient has a cone that's about 74 diopters as its maximum keratometry right in the center. And you can see in the picture on the left, in this case, the segment is much longer, about 270 degrees to fit around and wrap around the entire cone. And if we look at the difference map up top, we can see that with that segment, we're getting between 20 and 24 diopters of flattening. And clearly what you can see in the center is a much flatter, much more regular, and much more symmetric cornea. And this patient's vision can be significantly improved in glasses from the placement of this inlay. But what you can also see is the same type of inlay can be used to treat a much more mild case of keratoconus. So down below in the bottom left, this is a patient whose maximum keratometry is around 55 diopters. So almost 20 diopters less than the case above. And by placing a thinner segment and a smaller segment that wraps just around the cone, here we see about 4.5 diopters of flattening, but that's what this patient needs. And again, we see a much more symmetric and much more regular corneal shape, both in the more severe case and in the more mild case with a customized segment. Finally, we see this case here, which is again a very steep but asymmetric cone. So now the cone is no longer in the center, but it's out further in the periphery. And again, because of the customization of the CTAC segment, we can get it around the entire steep area around the cone, again, inducing close to 20 diopters of flattening. And you can see once again in the center, we get a much more symmetric, a much smaller cone with a significant amount of flattening. And actually, this case is the same patient that I showed just a few slides ago. This is the case of the patient who had double vision with their Intacs segment and is extremely happy with the CTAC segment. So again, with the CTAC segment, we can see that with further customization and our ability to really fit these segments right around the cone, we can get really, really great topographic and visual results. The last thing I wanted to show you tonight is kind of how the CTAC segment looks in the cornea. So Dr. Hirsch had gone over before that when we place the Intacs segments, we elevate the cornea. And by elevating the cornea, we flatten the cornea just inside of the segment. But what you can see with the CTAC segment is we get the same kind of elevation above with flattening inside, but the CTAC segment takes on the contour of the cornea. So it has a much more regular shape in the periphery. And actually, as Dr. Gelles can touch on a little bit more, it makes the contact lens fitting over these segments much easier. And you can see the difference. We can place thicker segments, and then we can place thinner segments. And in both cases, the contour of the cornea stays very regular and very symmetric. So now Dr. Gelles is going to discuss how we fit contact lenses once we've placed Intacs, and maybe he'll touch a little bit on placing the CTAC segment.
Perfect. Thank you so much, Dr. Greenstein. That was a perfect summary here and lead into the contact lenses. To kind of understand contact lenses after implantation of Intacs, we took a look at eyes who had been fit with contact lenses after the cross-linking and Intacs procedure. And we ended up looking at about 110 different eyes. These eyes had only undergone cross-linking and Intacs. There was no other procedures like Topography Guided PRK or CK used on these eyes. And what we looked at was what type of lens were they ultimately successful in. And the 4 types of lenses that we had defined with this are custom soft lenses, hybrids, piggybacks, and scleral lenses. And as you can see here on the graph, the vast majority of these individuals do very well in vaulting designs and soft designs. Very few of these individuals, in fact, none in the cohort, did well in corneal gas permeable lenses without a soft lens underneath. So why do we see this? Well, part of the reason is because of epithelial remodeling. When we look at the epithelium over a typical keratoconic cornea, we can see that the epithelium thins over the apex and becomes thickened around the base of the cone. Well, when we put an Intact into a cornea, we end up getting the same sort of remodeling around it. We get thinning over the top of the Intact segment and thickening adjacent to it. What this does is it creates a thinner spot over that area. And when we use a corneal gas perm lens, it's going to land in that area. When we think of a corneal gas permeable lens, generally, or even a hybrid lens, what we're getting is we're getting the rigid portion of the lens contacting the cornea at about 6 to 8 millimeters, and or a 6 to 8 millimeter optic zone, and that's rubbing right over the area of the Intact segment, and that thin area of epithelium begins to break down. So what we end up getting is these epitheliopathies right over the Intact segment. So you can see this bearing that's happening right here. So we want to ensure that the lens is up over the segment, because bearing on these areas is essentially going to cause a plastic sandwich. In a way, we're getting the Intact segment, the corneal tissue, and then a rigid contact lens over the top of it. And that rubbing is causing epitheliopathy. And if we have too much of that, we can end up with breakdown of that area. Now, what our choice is to going into vaulted and soft designs. So when we see these individuals with Intacts, it shouldn't be much of a challenge for us to fit these individuals. We should be able to see these individuals and look at our contact lens toolbox and say, hey, they're probably not going to do well with lenses where a rigid lens is going to contact the surface. So let's look at a vaulted, such as a scleral design, or a soft lens design to be able to achieve a good outcome with this. Now, when we look at CTAC specifically, CTAC, because the tissue is made out of cornea, it tends to respond a little bit better to lenses that are landing on it. There is still an epithelial remodeling which happens with it, but generally the massive amounts of curvature change that are provided by this create a much more normalized corneal surface. And we found many instances in which individuals have gone from needing vaulted designs such as scleral lenses to being able to be successfully fit in things like custom soft lenses. So it's really opening a very interesting area of contact lens fitting, and these individuals do very, very well with it. Now, one note to have is that during the early post-operative period, those wearing scleral lenses, we do notice a little bit of thickening or swelling in the area where the CTAC is, but this seems to resolve over time. So something to just keep in mind of during that early post-operative period. With that, the summary on this is really that corneal inlays, specifically Intacs in this case, improve visual acuity, quality of vision, and the corneal curvature that is present. And we should use these as part of a comprehensive approach to keratoconus. We want to stabilize the cornea with corneal collagen cross-linking, improve corneal topography by using treatments such as these Inlays, CTAC and Intacs, as well as Topography Guided PRK or conductive keratoplasty, and then using our methods of correcting the residual refractive error with being contact lenses or glasses or surgical correction for these individuals to successfully manage them overall. We want to think a little bit about the comprehensive needs of individuals with keratoconus in that they wear their contact lenses for their best possible visual acuity. However, you should think about what's going to happen when they remove their contact lenses and their inability to be able to function with the vision that's left if we don't address those needs with those topography improving procedures to be able to give them functional vision when they're not wearing their contact lenses. Obviously, contact lenses being the mainstay of visual correction for these individuals. So the future of corneal inlays really lie in the corneal tissue addition for keratoconus, because this tissue inlay can be much more customizable. It can be used for both mild and severe cases. And because the placement is of natural collagen into the cornea, we'll likely see less biocompatibility issues as well. And with that, I'd like to go ahead and bring back on Dr. Greenstein, Dr. Hirsch, and Dr. Wu to go ahead and answer some questions in the Q&A.
Great. Thank you so much, Dr. Gelles, Dr. Greenstein, and Dr. Hirsch. That was a great presentation. And I think it's a topic that a lot of doctors are curious about. And I feel like a lot of people just don't know. And so we do have some questions. I don't know who wants to take these, but first question is there any restriction of Intacs or Inlays for pediatric population?
Typically, we don't do these kind of procedures in kids. We usually will treat the pediatric population with cross-linking alone. And if they can be effectively treated with a contact lens, I think that is safer for them. Because even with cross-linking, a younger population with keratoconus still could get worse over time. There may be the need for another cross-linking procedure. The earlier you get KC, the worse the KC tends to progress over time, and the more severe it tends to become. And although cross-linking, Dr. Greenstein, Ellis, and I just finished a 10-year review of our original clinical trial patients, it seems quite stable. We still need to be concerned about the pediatric population and follow them very closely. So right now, we're really not recommending adjunctive surgical procedures unless necessary for a particular child. One thing I do have to impress on everybody in the pediatric population is the importance of screening these patients. Because again, if you get KC early, it's going to tend to progress rapidly. So you want to catch the KC as soon as possible, because you want to get those patients into a cross-linking protocol as soon as possible. I think Dr. Gelles actually has some information, having just looked into this a bit. John?
Perfect. Yes. Yeah. When we look at the pediatric population in these individuals, we really want to, act as early as possible. You kind of think of it in a way of diagnose early, treat early, and prevent this progression from happening. And in the pediatric population, we really want to prevent that from happening. And the cross-linking procedure that is approved right now, and Dr. Hirsch, correct me if I'm wrong on this, but it was approved to 14 years of age, correct?
That's correct, yes.
And you can do cross-linking off-label on those individuals at a younger age as well. So if they do have those signs, you can do that. Now, as far as screening techniques, the three of us and Dan Chung, our research fellow, did a amazing retrospective piece of work looking at baseline characteristics in individuals with keratoconus, and found that a good screening, or rather a useful screening or need for screening finding was looking at the manifest refraction and the K values of the individual. And what we found was that if an individual had against the rule or oblique astigmatism of 2 diopters of manifest cylinder power or corneal cylinder power, that individual should get a corneal topography, and that topography may show keratoconus.
Mm-hmm. Yeah, that's those are really great points, and I know that the educational piece is so important because, like you said, Dr. Hirsch, you've got to get these kids screened early, and I think a lot of people are still very unaware that cross-linking exists, that it is covered by majority of insurances now, and it is a very, very safe and effective treatment option for keratoconic patients. So I'm so glad that you mentioned that, because that's a very, very important piece. Next question is probably for Dr. Gelles. How soon after Intacs before you can start fitting contact lenses?
So generally, for most procedures where we're doing an inlay, we typically wait till about the 1-month mark. However, they can be successfully fit or start the fitting at the 2-week mark. Generally, though, we wait until the 1-month mark.
Great, thank you.